3, 2, 1. We are live now.
So, greetings all the delegates of Pune Trauma Operative Course. This is the Atlas of Draping Techniques in Orthopedics, a video book that we'll giving complimentary to the delegates. The authors of this book are Dr. Madhav Khadilkar and Dr. Shantanu Deshpande, who have painstakingly written down these basic steps as well as made videos in detail about all the draping techniques in orthopedics. So we at PTOC believe that this will be a great addition to all the postgraduates as well as trainee orthopedic surgeons. So thanks both the authors for compiling this book. With this, I hand it over to Dr. Khadilkar for introducing the book. Over to you, sir.
Okay. Hi, everyone. So thank you, Dr. Ashok, for the kind introduction. I am Dr. Madhav Khadilkar. I work as a professor of orthopedics at Bharatiya Vidyapeeth Medical College. And we have co-authored this book along with Dr. Shantanu Deshpande, who is my colleague and also works as an associate professor at Bharatiya Vidyapeeth. I would just like to give a short introduction to how this book came into being. Dear all delegates who are attending PTC and all the residents and the people who are doing their MS or post-graduation, as you all know, that surgical site infection for an orthopedic surgeon is a nightmare. And the most important key to a good outcome from an orthopedic surgery is a proper draping. Campbell's Operative Orthopedics, the so-called Bible of all the orthopedic surgeons, says that draping should not be left to an untrained assistant or a junior. And if the junior is not properly trained, the surgeon who is operating himself should be doing the draping. Having said that, we both of us did a detailed search of the net and other literature, and we did not find any books or any literature on draping techniques, nor have the textbooks, the standard textbooks that the residents use for studying orthopedics, have any vividly described the proper draping techniques. Most of the draping techniques that the residents learn are from their seniors as hand-me-down, and who in turn have learned it from their seniors. Being in the teaching profession for more than 30 years, I realized that in most of the cases, the person who is operating joins the operating table only at the last moment when the patient is anesthetized, prepared, and draped. And the draping part of this is left to either a junior resident or a lecturer or somebody who is junior, and the surgeon comes in only after everything has been done and prepared. So this particular tendency or trend led me to start thinking that we should do something and come out with a pictorial atlas of proper draping techniques by which we can teach the residents as to what and how the draping should be done. In Shantanu Deshpande, who also works, as I said, as an associate professor along with me, I found a like-minded person, and we both decided to finally come out with this pictorial atlas and a video book. This book is a result of a very meticulous planning and execution of photography and videography, which we conducted at the Bharatiya Vidyapeeth Medical College Operation Theatre. With the help of some of the techniques have been shot with mannequins, and some of them on actual volunteers. And we compiled this thing. I have to specially thank Dr. Ashok for compiling all these videos together. Actually, draping is a technique or a procedure. So Ashok felt that we should compile all these videos together and come out with a video book, which the junior or young orthopedic surgeons can actually view and learn how to drape properly. So I'm really thankful to Ashok for doing all this, taking this effort and compiling these videos into this book and giving us the platform of OrthoTV to launch this book in this prestigious conference that is going to take place, the Pune Trauma Course. in this month. So with this short introduction, I would now like to start with the actual videos. And for the first video, which shows how to handle the drapes properly, some short tips about tourniquet application and laying of the trolley. I would now hand over the proceedings to Dr. Shantanu Deshpande. Shantanu, please take over.
Thank you, Khadija sir. So, as aptly described by sir, the thinking behind this book, we have used very commonly performed surgeries in general orthopedic practice, and we are trying to use them to make sure so that our draping is done properly. And the most important thing for this is to get your basics right. So draping is a very important step in any surgical procedure, and time and again this has proven, especially a practical experience you will feel, if it is not done right, you will struggle in some proximal exposure in doing a hip or in trauma, and so let's begin the chapters. And the first and foremost is the drape handling. So it is very critical that the drapes that you open on the operating theater while using for the patient are properly folded so that it is easier to open later. So the person who is going to fold them and put it in autoclave, he should be adequately trained so that a single two-hand technique can be utilized for opening and drapes. So the same thing that you are seeing in the PowerPoint, you will watch this in the video as well. But the important three is, if you see those horizontal equal folded lines, and when you open one end, it is easier to drape the patient or the required body portion. So as you know, the autoclave or the preparation for the OT begins a day prior. So that's the reason, once you plan, make sure all your draping and equipment, everything is sterilized in a proper way so that your draping works and the instrument that you need for your OT, everything is planned for you to get executed on the table. So if you watch the video, the sheet is folded in equal parts starting at one end, and it is being folded on top of each other. It's not that the entire sheet is folded in halfway. So the equal parts divided and folded onto each other. So that basically help us to undo it in the same way like opening a book. So 2 or 3 folds for a big sheet would be sufficient. When you're using a sterile one, you can use this and just lifting a single ends, you will see the entire drape is opening up. So that is important. Now, similarly, as the drapes go, the trolleys are also important. So for draping the trolleys, we can use a plastic sheet that is covering the entire trolley, making sure the length of the plastic sheet is more than the width and length of the trolley, and it is covering the ends as well. Or after the plastic sheet is applied, you can use couple of drapes so that you get one impervious layer and on top of it another layer. This is a second way to drape the trolleys. Initially you have seen we have used a single drape to cover the all 4 corners. This one is used, this is actually a better technique, but the number of drapes required is more. So both ends you can cover with the long drapes. The height of the initial drape using a single wood cover only, middle third of the trolley. If you watch the second technique, you can cover almost up to the wheels of the trolley. And once you have put these two side drapes, you can put the third one on the top. And this way you can cover both sides, front and back, which is facing the surgical table, as well as the sides, because that's where the contamination can happen. Now, most of the orthopedic surgeries require tourniquet. So it is very critical that your tourniquet application as a preparation towards a good surgery environment is important. So we use gamgees and bandage under the tourniquet, but the width of the tourniquet and length of the tourniquet both are important. You have to make sure, looking at the circumference of the thigh, which tourniquet to be used. If you think that the tourniquet is smaller, don't just put it too tightly and use it. It's better to get another one and use it properly. Get your one assistant to hold the leg, one assistant to wrap the tourniquet properly, and making sure that gamgee or cotton that you use is again wrapped under the tourniquet. Now, very common problem when we do the scrubbing of the leg, the iodine preparation and the moistness goes under the tourniquet and can make the cotton wet. And that is a problem if your surgery is going on for a couple of hours, then the skin can get macerate and get injured. So the one more better way to control this happening is take a small cut in the plastic sheet, get the foot out of that plastic sheet as if the circular hole is snugly fitting the foot, and thigh being wider than the foot, it usually accommodates it very snugly and doesn't allow the fluid to go towards the under surface of the tourniquet. So these few steps will make sure that you are protecting the skin underneath and making sure there are no surgical error or complications happen. For the lower limb draping, I would ask Khadilkar sir to present it. Thank you.
Thank you, Shantanu. Just start the video after okay, you start it and then pause it for a while.
Initially few slides and then video.
Yeah, so basically this, now what I'm going to describe is the draping of a lower limb surgery. Either the part which is to be operated is either below knee, foot and ankle, or knee and the thigh. The patient here is in a supine position. The anesthetized patient is kept in the supine position. The limb is scrubbed and prepared properly by one of the assistants, and assistant who has washed up and gloved holds the limb. Now here you have to be careful that you prepare the entire leg, that is the entire foot and the web spaces between the digits, because basically you need to clean the foot completely so that it is held by a person. So this is a trolley which has been laid. Now we will start the draping. So first thing that you do is take a plastic sheet. The assistant, as you can see, is holding the leg somewhere just below the knee. The first sheet goes under the leg. The second sheet, you make a small cut or a slit in the sheet, and then you thread the leg or the foot through the small hole or a slit that you have made in the plastic sheet. Once you have threaded the foot through the small hole, you pull the sheet up the leg till you isolate the amount of leg that you want to keep it open, or which actually keeps the operating area open. So because the leg goes on becoming wider as you go up, as you pull the sheet up, it automatically tears and accommodates the leg. So basically here I am showing you the video for below the knee surgery or below knee draping, you go only up to the knee. If you want to keep the knee also open, or you are operating or doing some procedure on the lower thigh or the knee, then you keep on pulling on the plastic sheet. It goes on tearing and goes right up to the upper third of the thigh where the tourniquet is applied. So after you have isolated the part with 2 sheets, now you take a medium size of sheet. The assistant has now moved to the foot end and he is holding the foot. You take a medium size of sheet and put it on the plastic sheet below the leg. Next, you take another big sheet now and open it with the from both the sides and take it around the thigh, bring both the ends anteriorly and secure it just below the tourniquet with a towel clip. Here take special precaution that you don't puncture or pinch the tourniquet, because if you are using a sharp towel clip, there is a danger of puncturing the tourniquet. So be careful where you are applying the towel clip. Now take a second big sheet and put it on the thigh and the upper body. Take the 2 ends around the thigh and secure it with a towel clip again, either on the posterior aspect of the thigh or on the lateral aspect of the thigh. So now you have isolated the upper part of the body and the thigh from both the sides, from anteriorly and posteriorly. Now take a big sheet and spread it and bring it up to the tourniquet and cover the entire lower part of the table. Let the sheet go right up to the floor to cover the lower part of the table. Nothing should be exposed. Now take one more sheet from the upper side and medially and laterally secure these 2 sheets, one from below and one from above, with towel clips. So now you have 2 layers. The first one was inside and now these 2 sheets you have covered. Depending on the surgical area that you are operating on, you need to cover the part of the foot which you are not going to operate on with a mop, which you tie a knot around it, and then to keep the mop in place, you turn a glove on it so that it remains in place. So as you can see, you can put an extra bandage to secure the glove in place so that it doesn't slip off. So now you can see that the lower extremity from ankle up to the knee joint is exposed. So if that is the area that you are operating on, you have a completely isolated area. The entire or the rest of the field is completely covered by your sterile drapes. And this will avoid complete contamination. So this is for the leg and ankle. If you want to operate, say, on the heel, what you can do is, instead of pulling the glove over the heel, you can keep it and just cover the toes. So this is for the leg below the knee. Now, I think there is a short video which will, yeah. Now here we can see that if you are operating, supposing on the area which is closer to the knee or the lower thigh, the technique basically remains the same. Only thing is, in the previous video, you have seen that we have isolated only the foot and ankle. In this particular case, because your operating field is either knee or the distal thigh, you don't want the rest of the leg to be left open. So you completely drape it inside and cover the leg and see that only the operating field is left open. So this is again a short video of the same procedure. But again, as I said, here you are probably going to do it on the knee or the thigh. So there you go. So here, instead of a mop, you have taken a big sheet and you have covered the foot, ankle, and the lower third of the leg in the sheet, which you will secure in place with either a clean wrap or a roller bandage, depending on the availability. So here you can see that the knee and the upper third of leg. So this type of draping would be useful in any surgery on the knee or on the upper end of tibia, where you don't really need to keep the ankle, foot, and the lower third of the leg exposed. So you secure it with a bandage.
Yes, so you're done.
Yes. Okay. Thank you. So this basically is about the part of the lower limb from the mid thigh to the ankle and foot. Now we will go to draping of the hip in a lateral position. That is either for Austin Moore or partial hip replacement or total hip replacement. I'll hand over it to Shantanu to proceed with the draping of the hip in a lateral position.
Thank you, sir. So as you are seeing, the basic theme remains the same, that we have to isolate the lower leg with a plastic sheet. On top of it, there is a big cloth sheet and there is another cloth sheet. But important situation in the hip area is the contamination from the groin. So you have to make an extra effort here, making sure give critical attention to the groin isolation. You can use couple of drapes there, but make sure it doesn't get exposed while you are in the middle of the surgery, because that's where very likely a contamination from yourself or your assistant is likely to come into the operating field. So big drapes important. You will need 3 or 4 long big drapes to cover the hip in lateral position, as well as few short drapes. So the video basically would show you these steps in detail. So whenever you're using this plastic sheet, make sure it covers the entire lower limb and both sides. Now the first cloth drape that comes is covering again the plastic sheet and ends. A second long big drape comes. The proximal ends are now taken across the groin area and hold together with the clip. So this is where you are starting to isolate a groin. Now another sheet comes from the top and the two ends of the sheet are taken in the groin area or posteriorly or anteriorly, depending on what is your operating incision, and making it secure that it is covered on both sides. On top of this, we are taking two medium-sized drapes and they are coming from front and behind. So the drapes which are used in a curved fashion doesn't really cover the entire. This is an extra step, using a medium-sized drapes to cover the groin from the front and back. Now the third drape comes, that is going to hold the foot end of the leg in sterile zone, making sure till now your assistant who has been holding the leg has not touched the drape, your sterile drape part or the lower end of the table. So that is one more important step, that he holds the foot away from his body with both the arms in full extension. Once you have done that, then the leg can be left onto the trolley or the surgical table. Now this is a proximal drape which is going to cover the body. The ends of this drape can be used as a curtain, but because there are only, this is a second drape on the proximal side, we would advise a third drape that is going towards the anesthesiologist and making sure the side ends of the arm or support, the hip support, the pelvic support is also covered in this. If looking at this, if you still have a doubt where the low leg is going to come towards the ground when you are going to do a surgical procedure or when you are trying to reduce the hip, that's a stage where an extra drape is being used from the edge of the table towards the ground, making sure during the surgery, during the procedure of reducing the final prosthesis of the hip, we do not want some part of the lower end of the or the surgical table being open and the foot is touching that unsterile zone. So this is an extra precaution for bipolar surgeries, hip replacement, hemiarthroplasties, THR surgeries, that you are making sure that the foot which is going down is not touching an unsterile zone. So now I will hand over to Khadilkar sir for doing a hip surgical procedure, but on a fracture table.
Okay, thank you, Shantanu. So now we come to one of the most commonly performed surgery by the orthopedic surgeons, that is a fracture of the upper end of femur or fracture around the hip joint. It could be either an intracapsular fracture of the neck femur, or it could be an intertrochanteric or a subtrochanteric fracture, which most of the orthopedic surgeons prefer doing it on a fracture table. So here is the view of the operation theater where an anesthetized patient with an intertrochanteric fracture is fixed on a fracture table. So that was a lateral view, one is from the view from in between the two lower limbs. As you can see, the leg to be operated is the right one, which is straight. The other leg is flexed, abducted, and externally rotated in the hip, so as to allow good space for the C-arm to go in for the AP and lateral views. Because for a lateral view, this C-arm tube has to go below the hip and come up on the other side. So these are slides which you are just seeing of how you drape. We will come to the video shortly. Yeah, so this was the final draped picture of the patient. Now this is the video. So the patient is fixed to the fracture table, is scrubbed and now painted. First, you take a plastic sheet, a big plastic sheet, and you just put it over the lower limb. Because of the betadine, it will stick to the lower limb. Now you take a big sheet and cover the distal extremity below the knee. One big sheet you take and cover the upper part of the body. The third sheet you cover the opposite limb. Now, on the lateral side of the operated limb to be operated, you put a big sheet. Yeah, and then suture these ends. Okay, so these are, okay, now these are stitches being taken to secure these big sheets which have come from all the sides, one from the above, one on the opposite limb, and one on this side. All of them are secured in place by stitches or ethylon stitches which you take through the sheet and superficially through the skin, so that they don't move or come out. So as you can see, this is all the sheets have been secured. Yeah, now this one is a very important sheet. It's a big sheet at the upper part, which goes right from the chest wall right up to the floor. The last one, Chandu. Yeah. Yeah, this one. So basically, you can pause for a second. So yeah. So this sheet, if you see, it is going from the body of the patient and flowing down to the bottom of the table or almost to the floor. Now, this is a very important sheet because when you are doing a lateral view of the hip joint with the C-arm comes in between the legs under the table. So it comes out through a completely unsterile area and then swings up to come in the lateral position to show you the hip laterally. So if you don't have this proximal sheet placed properly, it can move a bit and the C-arm or the tube of the C-arm can come out of the sheet and contaminate your field while taking a lateral view. So this I feel is a very important sheet. Okay, so with that we come to the end of the draping of a fracture table. Lastly, you put a screen and isolate the head end. The anesthetist takes the sheet and puts it over the, yeah. Lastly, you cut the plastic drape and turn it onto itself like this from 3 sides. Keep one side intact and just turn it onto itself. Clean it with sterilium and your operating field is ready for you to start the surgery. Thank you. So this was draping of a patient on a fracture table. Shantanu, can you hear me?
So I'm going to pause the share for a minute.
Huh.
So पुढचं आता करायचंय.
Poonam? Hello, are you there, Poonam?
नाही ते बहुतेक
Do we continue and do it completely? काय करायचंय?
So उद्या करायचं का आज करायचं विचारूया त्याला.
Yes, sir.
Hi, Poonam.
Yes, sir.
Sorry. So about 5 or 6 videos we have done. I'm not sure how the last one has come because the internet was not very stable. So I was speaking at one speed and the video was moving at some other speed. So the last one which we did.
Okay.
So can you just check whether it has come up well or do we need to redo it or what? The last one.
Sir, right now we cannot check. Actually, it is going live. So when we go, when we do end, then only we can check whether
Achha,
it was.
You will be able to check only while editing, right?
Yes.
Okay. So now, okay, let it be then. You will see later on if there is anything to be redone or something.
Okay.
Secondly, we have almost done the half of the book.
Okay.
Now, do we continue and finish it today or we do it tomorrow?
Sir, can I ask Ashok sir?
Yeah, you please ask him.
Okay.
That we are through with half of the book.
Okay.
So there are about 4 or 5 chapters remaining.
Okay.
I think if we have to continue with it, then it will take another 45 minutes at least.
Okay.
30-40 minutes.
Okay, I will ask him and then.
Yeah. We are exactly halfway actually.
Okay.
So you just ask Ashok sir that whether we continue or we do it tomorrow afternoon again. One small session of about 45 minutes and we can finish it tomorrow.
Okay. Okay.
In the meantime, maybe tomorrow morning you can even go through this recording that we have done and see if we need to change anything, any corrections or anything.
Okay, sir.
Yeah,
Sir,
so-
wait for 5 minutes. I will let
I'll
you
wait.
know.
I'll wait for your message.
You can stop the YouTube live as well if you are doing live. Poonam,
Yes, sir.
if you are doing a YouTube live, you can stop for a minute till you are confirming.
Okay, sir.
Hello. हा. हो म्हणजे मी आता तेच युट्यूबच उघडत होतो, मी बघायचा प्रयत्न करत होतो की ते दिसतंय का, कुठे तुला दिसतंय का? मगाशी अशोक पण बोलताना सुरुवातीला म्हणला की वी आर रेकॉर्डिंग लाईव्ह म्हणून. तर ठीक आहे ना.
Hello, sir. I have talked to Ashok, sir, and he is telling that you can also continue today if you want.
Okay, another 30-40 minutes?
Yes, yes.
Okay. Just a minute. We'll see what Shantanu has to say. Shantanu,
Yeah, we can continue. Sir.
करून टाकायचं?
हो करून टाकू.
It will be in continuity, no?
Yeah. Okay. So
Yes.
we'll go ahead. No problem.
Okay, sir.
So what is the next one?
So upper limb in supine position. So spine you are doing late at the end.
Huh.
So I'll take upper limb in supine, then yours is lateral position.
Yeah.
Okay. So I'll resume the share. You're able to see upper limb draping. So we operate on the upper limb in supine as well as in lateral position. So here we are looking at the supine position. The arm is held by an assistant, and the drape that we are going to use, the sterile plastic drape, we can use two drapes here. One goes onto the hand trolley and the second one is cut and the arm is threaded through it so that it covers the tourniquet. We will be using few drapes on the trolley as well as on the body that we will appreciate in the video, and we have to really make sure that the entire body is covered at the end, including the head end. Elbow surgery, wrist surgery, depending on the area, the isolation can be variable as per your incision. So the assistant is holding the arm. You can actually make the assistant wear a sterile gown so that even if it's inadvertently get touched to the trolley or hand, there is no contamination. So first plastic sheet is put onto the hand trolley. A second plastic sheet is taken now. That is made a small cut, and that sheet is now taken up to the tourniquet, making sure you seal that area of the tourniquet. The drapes are used. The first drape goes on to the sterile plastic drape. The second bigger or longer drape comes, but the proximal ends are being circumferentially turned along the edge of the tourniquet and hold secure with the towel clip. Another big drape comes in, but now this is coming from the head end. The distal end of the drape can be turned similarly across the tourniquet lower edge, and it is secured with the clamp. Now, the second layer onto the trolley comes, that is covering edges of the axilla and the head area. Another big drape comes. This drape is covering the proximal part of the head, the anesthesia tubes and lines, and almost going on to the opposite limb. What is remaining now is the lower end of the body. So a big sheet is taken covering the entire lower end of the body and up to from toes up to the chest. Now, if you are operating on the forearm and there is no need to look at the wrist or the fingers, then one can use drapes, or you can even use a bandage, mop, and isolate the thumb. Another drape comes that is for isolating from the anesthesiologist over the two IV stand. This way, one can isolate from wrist, forearm, elbow, and lower end of the humerus. So, for wrist and the hand, only you can isolate different areas and check. Most of the areas remains the same. Draping technique remains the same, except for if you're operating onto the hand and the fingers, then the extra drape is taken to cover the middle third of the forearm, going up to the tourniquet. So that is something to remember, that our surgical plan and incision is going to dictate which area or extra drapes you are going to use, but make sure you use it as a double drape. Then the hand portion can be rested onto the trolley. Thank you. Now I will hand over to Khadilkar sir for lateral position draping of the upper limb.
Yeah, thank you, Shantaru. So here we now come for the draping of the elbow and posterior arm in a lateral position. So this is the most common position that we use while operating on the intra-articular fractures of the distal end of humerus, shaft of humerus when you are doing a posterior exposure for plating, or olecranon fractures and upper third ulna fractures, radial head excision. So all these surgeries, you require a patient in the lateral position with the affected side up and the arm dangling on a pillow or attachment to the table. So again, here, as you can see, this is a live volunteer, not a mannequin, because it was not possible to turn the mannequin on one side. So we have used a live volunteer. He is one of our lecturers who agreed to do it for us. So the anesthetized patient is on the lateral side with the limb to be operated held up. These are the various photographs of draping. Now we'll come to the video. So here the patient is lying. So again, the first thing that you do is isolate the part with a plastic sheet. the assistant is holding the scrubbed and prepared hand. So this is the second plastic sheet which we have been constantly telling you about, through which the hand is threaded and it goes right up to the edge of the tourniquet. Now comes the first cloth sheet. It's a big sheet which covers the armrest and it goes right up to the tourniquet, over the head and the chest. The second sheet is unfolded and is allowed to drop on the other side, and then the two sheets are secured, one in the axilla and one just above the shoulder or above the arm, just below the tourniquet, with two towel clips. Again, take precaution that you don't puncture the tourniquet, otherwise you will have a tough time while operating. One more medium-sized sheet goes over the head end. A second one comes from below. So as you have seen in all the surgeries, everywhere we are using two layers of drape. It is never a single layer of drape. Coming from two different directions, we are using two layers of drape. Now a big sheet goes on the lower part of the table and covers the lower extremities and the lower half of the body. The last one, it's a small or a medium sheet which takes the forearm and the hand, covered it completely, and is secured either with a roller bandage or a clean drape, depending on the availability. So here, as you can see now, the area that is exposed is the upper third of forearm posteriorly, the elbow posteriorly, and the arm posteriorly. So as I said, this is the position which is required when you are operating on the humerus from the posterior distal end of humerus intra-articular fractures. So there you go. So the hand is now resting on the armrest, completely draped and isolated. There goes the anesthesia screen, which isolates the head end and the anesthesia trolley from your operating field. So that is the way how you ideally drape for the arm and forearm, upper third forearm and elbow for a posterior approach. Thank you. Shantanu, you.
Right. So now regarding the upper limb, a shoulder is and the arm in supine position is remaining. So that we'll cover in few presentation slides and video again. So for supine position, we have to really make sure that our drape is gone under the scapular blade. So many times we put some support under the scapula, either roll sheet or hard material or a water bottle, so that the shoulder comes up. So that gives a bit of few inches of space from the table, and this actually helps you to make sure your drape goes under the body or up to the scapular edge, making sure that there is no contamination happening from that side. So the rest of the body is to be covered. But as we spoke about groin area, the critical area in upper limb and shoulder is basically axilla. So we really want to make sure that the axillary portion doesn't get exposed during the operative work. So plastic sheet which is used initially, we take a Alice or a swab holder and making sure that it is pushed underneath the body. Taking another drape from the top, a plastic drape. So 2 plastic drape usually help you to cover the entire body. Because of the gravity, your fluids are going to leak or go down towards the table and under the body. So you have to really make sure you are keeping it dry and there is a bit of sterile cloth cover between the surface of the table and a posterior part of the shoulder. So this really would help in isolating the shoulder area. The second drape comes in from the top. It is curved around the shoulder and then it is secured to the initial cloth drape that we are used. One should make sure that it is not tightly bound, leaving an adequate gap onto the anterior shoulder surface for your extension of the shoulder incision if it is required in depending on the surgical scenario. Once you have left an adequate cloth to cover and make it lax, you can isolate that area using extra drape coming from that side and getting secured to your drape which is covering the anterior axilla. Making sure that this drape also covers the opposite arm is important so that whenever the C-arm is coming from that side, there is no unsterile surface coming in contact. The lower limbs or the legs are and the rest of the body is covered, and arm and the forearm is covered depending on your extension of the incision. If you want to leave the elbow free, then only use the forearm and wrist and hand in the drape and secure it with the bandage. By doing this, you are making sure that axilla and the space between the fingers, which are likely to be a contaminated area, are not being exposed. Now the final drape comes for a curtain across the anesthesia site and covering the tube or head end of the patient. Thank you. So I'll hand over to Dr. Khadilkar now. So we'll be covering the spine area draping now.
Yeah. Thank you, Shantanu. So you have the video for cervical spine?
Yeah.
Shantanu?
I'll take the
You are muted. Unmute yourself, Shantanu. Shantanu, you are muted.
Yeah.
Okay, so you have the videos. Now next video is what?
Cervical spine.
And then one dorsal spine and one bone grafting. Only
Yeah.
3 are remaining, I think.
Yeah.
Okay, so you want me to take the cervical spine?
Yes, sir.
Okay. Okay, so cervical spine in supine position. So usually it's a very small area that you operate upon, that is between the supraclavicular area anteriorly to the base of the neck. So this is the area that you are looking at, and Yeah, can you just start the slideshow? Okay, so basically these are some of the slides. So you first take a plastic sheet, put it on the chest, covering the abdomen. Basically, it's not a very difficult thing to drape a cervical area because it's a very small area or the operating field is not very big. You put a large plastic sheet first, which goes from the clavicle below, covering the chest and the abdomen. Okay, that is the first sheet. This is now covered with a cloth drape, which will go from the edge of the plastic, yeah, to the pelvic area. Now, the second sheet comes from the head end, fold it, the edge, fold it onto itself, and just let it fall just at the level of the chin. The big sheet here is now covering the lower half of the body, the legs. So as you can see, part of the iliac crest is being left open in between. So probably that is also taken care of for the graft that you may need for the cervical procedure. So here now two sheets come, one from the right side and the other from the left side. Depending on the operation site or the side from which you are going to go in, you leave that much area exposed and rest of the area you just cover with 2 layers of drape. So as you can see, it's just a rectangular area of the neck which is left open. Take the second layer of drapes and put it on. Lastly, put the screen on, which will isolate the head and the anesthesia trolley from the operating field. So the operating field is not seen very clearly here, but as I said, right from the base of the chin, it goes up to the upper end of clavicle, a rectangular area which is left open. Yeah, so that is the area which you can see, wherein you operate on the anterior cervical area, whatever, either excision of the disc, plating, bone grafting, fusion, all these surgeries are performed from this small incision. Okay, now we go for the iliac crest bone grafting. So again, the patient is in the same supine position, anesthetized, scrubbed and prepared. One plastic sheet goes above, one below, and then similarly, just a small rectangular area of the iliac crest from where you need to take the graft. So this is the video. So you isolate the iliac crest from all the 4 sides, leaving only a small square or a rectangular area of the iliac crest exposed from where you need to take a graft. What is not shown in the video is before you start draping, you put a sandbag underneath the side of the buttock from which iliac crest you are going to take the graft, so that you elevate that side and make the iliac crest prominent. So as you can see, all these incisions would do better because there are just 4 sheets coming from 4 sides, isolating the or leaving that operating field area open. It's always better to use adhesive Surgery drapes like Surgery drape, which are adhesive, so that they keep the sheets in place, like IOBAN or Surgery drape, which are adhesive, and they would keep the sheets secure in place and not allow them to slip and fall or move away from the operating field. So that was about anterior cervical spine and iliac crest bone graft. I will now hand over the proceedings to Shantanu to take you through the dorsal lumbar spine in prone position, draping for that.
Right. So for prone position, very important is to make sure there is no pressure onto the abdomen, because if it pressurizes, then pressurize the IVC return, and there are issues with the blood pressure. So your abdomen should be free. At the same time, it should support the body nicely. So these are the slides, initial slides, which are showing you how the drapes are going to be proceeded. And this is our area of surgical interest, which is depending on your length of the incision is exposed, and all four sides are draped. So the video shows making sure that whenever the patient, or this is our volunteer which is sleeping, is having an adequate breathing space and abdomen to move in normal fashion. The lower part of the body and upper part of the body is covered with two different plastic sheets, so that it gives a good cover and isolation to the spine area. One big sheet is used in the lower half, another big sheet is used in the upper half. So what is remaining now are the two sides. Your incision is going to be the central zone. So two sides of the body and the spine are covered with a folded big medium sheet, but making sure that the ends almost go down up to the floor, covering the entire surgical table. So once the all four sides are initially draped with the single cloth drape, we used another cloth layer, giving a double isolation of the surgical area. The final drape is now used for isolation from the anesthesia team as a curtain, and a adhesive surgical drape is now put across the surgical zone. An extra layer is covered from the surgical zone up to the foot before the lines and suction and everything is connected. Okay, so this is very important that the surgical zone is well exposed and well covered depending on the surgical incision. So we are coming to the end of the presentation and our surgical video book. I would hand over for Khadilkar sir for final remarks. Yes, sir.
Okay. So thank you very much, Shantanu, for the wonderful videos and the commentary. So once again, I would like to thank OrthoTV and Dr. Ashok Sham for giving us this opportunity and taking the pains to compile these videos and allowing us to launch this video book in this prestigious Pune trauma course. So thank you, Ashok, once again. And good night. Shantanu, if you want to say a few words.
I think this will be very useful for surgical residents, and getting the basic right, basic things, basic knowledge, basic procedure rights is the first and foremost step for a good surgical behavior in the life. Thank you.
Also, OT personnel would benefit from this, I feel. Not only the residents or junior orthopedic surgeons, but the OT personnel who scrub or wash up for the surgeries. I mean, even they should be made to watch this and make them aware of the nuances of the draping techniques.
Okay. Thank you.
Thank you very much. Thank you. Poonam?
If Ashok Sham wants to say something.
तो नाही आहे मला वाटतं इथे.
Poonam,
Let's close.
just close.
Yes.
Okay.
Okay, sir.